Introduction. Tourette Syndrome, TS, is a complex neurodevelopmental disorder characterized by involuntary movements and vocalizations known as tics. It was first described by the French neurologist Gilles de la Tourette in 1885. TS affects approximately 0.3% to 1% of the population, with onset typically occurring in childhood. The exact cause of TS is still unknown, but it is believed to involve a combination of genetic and environmental factors. This script will provide a comprehensive overview of TS, including its clinical presentation, diagnostic criteria, pathophysiology, neuroimaging findings, genetic and environmental factors, pharmacological and behavioral interventions, deep brain stimulation, cognitive and neuropsychiatric features, and prognosis and quality of life. Tourette Syndrome, TS, is a neurodevelopmental disorder characterized by the presence of motor and vocal tics. It is classified as a tic disorder within the spectrum of neuropsychiatric conditions. Tics are sudden, rapid, repetitive, and non-rhythmic movements or vocalizations that typically occur in bouts. Motor tics can manifest as eye blinking, facial grimacing, head jerking, shoulder shrugging, or limb movements, while vocal tics may include throat clearing, coughing, sniffing, grunting, or the repetition of words or phrases. Tics can be simple or complex, and they may change in location, frequency, and intensity over time. The clinical presentation of TS can vary widely among individuals, both in terms of the types of tics and their severity. Onset of TS typically occurs in childhood, around the age of 5 to 7 years, and the presentation can be gradual or sudden. Tics tend to wax and wane, with periods of exacerbation and remission. It is important to note that tic symptoms may not be present all the time and can be influenced by stress, fatigue, anxiety, or excitement. Co-occurring conditions are common in TS, including attention deficit/hyperactivity disorder, ADHD, obsessive-compulsive disorder, OCD, anxiety disorders, and learning disabilities. The diagnosis of Tourette syndrome is based on the presence of both motor and vocal tics, which have been present for at least 1 year. The tics must begin before the age of 18 years and cannot be attributed to another medical condition or substance use. Additionally, the tics must cause distress or impairment in social, academic, or occupational functioning. The diagnosis of TS is clinical and relies on careful history taking and observation of tics by a qualified healthcare professional. The underlying pathophysiology of TS is not fully understood, but it is believed to involve abnormalities in the basal ganglia thalamocortical circuits. The basal ganglia, a group of structures deep within the brain, are responsible for motor control and the regulation of voluntary movement. In TS, there is evidence of overactivity and disrupted inhibition within these circuits, leading to the generation of tics. Dysfunction in other brain regions, such as the prefrontal cortex and limbic system, may also play a role in the development of co-occurring conditions. Neuroimaging studies, including structural and functional MRI, have provided insights into the neurobiology of TS. Structural MRI studies have shown subtle abnormalities in the basal ganglia, including smaller volumes and altered connectivity. Functional MRI studies have demonstrated aberrant patterns of activation and connectivity within the basal ganglia thalamocortical circuits, as well as in other brain regions implicated in motor and cognitive processes. These findings suggest that TS is a disorder of network dysfunction rather than a localized abnormality within a single brain region. There is strong evidence to suggest that genetic factors contribute to the development of TS. Family and twin studies have shown a higher concordance rate among monozygotic twins compared to dizygotic twins, indicating a genetic component. Numerous candidate genes have been implicated in TS, including those involved in the regulation of dopaminergic and serotonergic neurotransmission. However, the genetic architecture of TS is complex, with multiple genes and gene-gene interactions likely involved. While genetic factors play a role in TS, it is clear that environmental factors also contribute to its development. Prenatal and perinatal complications, such as maternal smoking during pregnancy, low birth weight, and certain infections, have been associated with an increased risk of TS. Additionally, psychosocial stressors, such as trauma and adverse childhood experiences, may influence the severity and course of tics. The interplay between genetic and environmental factors in TS is an area of ongoing research. Pharmacological management is often considered in individuals with TS who experience significant distress or functional impairment due to their tics. The first-line pharmacological treatment for tics is typically alpha-2 adrenergic agonists, such as clonidine or guanfacine. These medications can help reduce the frequency and intensity of tics. Second-line options include dopamine receptor antagonists, such as risperidone or aripiprazole, which are more effective for controlling complex tics and comorbid conditions. However, pharmacotherapy should always be individualized based on the specific needs and preferences of each patient. In addition to pharmacological management, behavioral and psychosocial interventions are important components of comprehensive care for individuals with TS. Behavioral interventions, such as habit reversal training, HRT, and comprehensive behavioral intervention for tics, CBIT, aim to increase awareness of tics and teach adaptive strategies to manage and reduce their impact. Psychosocial interventions, including supportive therapy, psychoeducation, and cognitive behavioral therapy, CBT, can help individuals with TS and their families cope with the challenges associated with the disorder. Deep brain stimulation, DBS, is a surgical treatment option for individuals with severe and debilitating tics that are resistant to other interventions. DBS involves the implantation of electrodes into specific brain regions, such as the thalamus or globus pallidus, which are then connected to a neurostimulator device. Electrical stimulation is delivered to modulate the dysfunctional circuitry and reduce the severity of tics. DBS is considered an invasive and irreversible procedure and is typically reserved for cases in which other treatments have not provided sufficient relief. In addition to motor and vocal tics, individuals with TS may also experience cognitive and neuropsychiatric features. These can include difficulties with attention, executive functions, impulse control, and social cognition. ADHD is the most common co-occurring condition in TS, affecting up to 60% of individuals. OCD, anxiety disorders, and mood disorders are also commonly seen in the TS population. Understanding and addressing these associated features is crucial in providing comprehensive care for individuals with TS. The prognosis for individuals with TS varies widely. While tics frequently persist into adulthood, they often decrease in severity and may even resolve completely in some cases. However, co-occurring conditions and associated functional impairments can have a significant impact on quality of life. Early diagnosis, appropriate treatment, and ongoing support are essential for optimizing outcomes. With a holistic and multidisciplinary approach, individuals with TS can lead fulfilling and productive lives. In conclusion, Tourette syndrome is a complex neurodevelopmental disorder characterized by involuntary motor and vocal tics. It involves a combination of genetic and environmental factors that disrupt the functioning of the basal ganglia thalamocortical circuits. Neuroimaging studies have provided insights into the underlying neurobiology of TS. Treatment approaches include pharmacological management, behavioral and psychosocial interventions, and, in severe cases, deep brain stimulation. Co-occurring conditions and associated cognitive and neuropsychiatric features require comprehensive care. With appropriate interventions and support, individuals with TS can achieve an improved quality of life.